Hello, my name is Pearl Huey. I'm a biomedical scientist working in the cellular pathology department in Betsy Cadwallader University Health Board. The background to this project was a passionate plea from our clinical colleagues in respiratory medicine to try and help them improve outcomes for our lung cancer patients. This project brought together multidisciplinary teams from across Wales to evaluate the possibility of using a fully automated platform to deliver rapid EGFR molecular testing locally. This is in order to help optimise treatment options for very ill patients who present with late-stage lung cancer. These patients may currently miss out on the opportunity to benefit from life-prolonging targeted therapy, as they are often too ill to wait for a full molecular profile from Cardiff before initiating treatment. Due to COVID-19, patients are delaying seeking medical advice, and hence are likely to present with more advanced disease requiring urgent medical intervention. Non-small cell lung cancer accounts for around 85% of lung cancers in the UK. Depending on the patient's medical status and stage of disease at the presentation, treatment options include surgery, radiotherapy, chemotherapy, and more recently, personalised targeted medicine. Identifying specific genetic mutations associated with this type of lung cancer can help determine which patients are more likely to benefit from one of the many new targeted therapies. In the UK, NICE recommends that PD-L1, ALK, ROS1 and EGFR molecular testing is routinely carried out for all adults with previously untreated, local advanced or metastatic non-small cell lung cancer. This is in order to inform clinical management. Around 16% of these patients will have a mutation in the EGFR gene, and these patients will show a greater response to EGFR tyrosine kinase inhibitors than they do to traditional chemotherapies. Conversely, patients without such mutations respond better to conventional treatments. Clinicians therefore need to be able to identify each group of patients to ensure optimal treatment. Molecular testing can be delivered in a variety of ways. Immunohistochemistry is a reliable method for PD-L1, ALK and ROS1 rearrangements, but DNA sequencing methods are recommended to test for EGFR mutations. Next-generation sequencing is the method of choice, as it can screen a large number of cases for a wide variety of mutations at the same time. However, most genomic testing methods involve complex preparation of the specimen in a clinically clean environment. It also requires specialist training of laboratory staff and extensive clinical expertise to ensure correct interpretation of results. This often results in a turnaround time of around 2 weeks. It is important at this stage to highlight that NGS is widely regarded as the gold standard for molecular testing, and use of the rapid near-patient tests are only intended as an adjunct to be used only when deemed clinically necessary. Lung cancer is the most common cause of death from cancer in the UK. Between 2016 and 2018, there were over 6,500 lung cancers diagnosed in Wales. Many lung cancers are not detected until they reach stage 4, when the cancer has already spread. These patients are often very ill, and in many cases the results of molecular tests are needed the same day. This is in order to decide on the most beneficial therapy. Unfortunately, Welsh patients currently have the lowest overall survival rates compared with other UK nations, and Wales ranks 27th out of 28 European nations. Time to treatment translates into survival, as seen here in the Cancer Research survival statistics. To arrive at a diagnosis, a small sample of tumour is removed, processed in the local histology laboratory, and the sections produced is viewed by a consultant histopathologist to deliver a diagnosis. In an attempt to expedite urgent reports, most histology labs have already implemented local testing for PD-L1, ALK and ROS1 using immunohistochemistry techniques. But this is still only of limited benefit, as the oncologist also requires EGFR tests to initiate treatment. EGFR tests are currently sent to the All Wales Molecular Genetics Lab in Cardiff for DNA sequencing using next-generation sequencing equipment. Specimen transport issues and the complexity of testing results in a turnaround time of around 2 to 3 weeks for most molecular tests. NICE guidelines, the optimal lung cancer pathway and the suspected cancer pathway all recommend a targeted turnaround time of no more than 3 days for histology, plus an additional 10 calendar days for molecular testing. This project had a long list of tasks. Firstly, to evaluate the anecdotal need for urgent EGFR testing. We audited the turnaround time to identify all the pinch points in the pathway. Next, we investigated what fully automated platforms were available for rapid EGFR testing. We then validated the platform identified, developed a standard operating procedure, along with defining a user guide. Finally, we spent some time working on speeding up the transmission of reports. The user survey shows a clear requirement for a rapid EGFR test for a limited group of patients. 100% of respondents saying they would like a quicker result. 3/4 of those questions had encountered patients who would have benefited from a rapid EGFR result. An independent review of available testing platforms was undertaken. It was specified that we required a fully automated platform that required no specialist premises. The platform had to be CE approved and well established in other reputable labs within the UK. It had to be easy to use and provide clear, easily interpreted results with built-in quality control. We needed minimal manual intervention so as not to impact on the workload of already busy histology laboratories. The system had to be cost-effective and have the ability to deliver a reliable, clinically actionable result within 24 hours of diagnosis. The study confirmed that the iDILA was the only platform currently available to meet all these criteria. The iDILA platform is compact and no special clean environment is required, very simple to use with no extensive training required. The results are available within 3 hours of requesting the test. The cassette contains a panel of all currently clinically actionable mutations in exons 18 to 21 of the EGFR gene. The system is also CE approved and currently in use in over 50 labs in the UK. For the validation, 93 tissue samples from patients with non-small cell lung cancer were examined. 97% of cases showed concordance between the NGS and the iDILA results. 74% were negative by both methods, and 23% were positive by both methods. However, 3 of the results were discrepant. All 3 were very rare mutations detected by NGS. None of them are currently clinically actionable and hence were not included in the iDILA screening platform. A standard operating procedure was prepared, mapping out the procedure and detailing the limitations of the technology. The SOP also detailed essential quality control scheme enrolment, as well as training and qualifications required to deliver the report. Whilst the All Wales Molecular Genetics team did not wish to endorse the iDILA platform, they kindly agreed to provide advice to assist in its implementation in histology labs. This is in order to facilitate a rapid result when the clinician deemed an urgent report was needed to direct patient care. In order to alleviate concerns raised by the genetics team relating to reliability of the iDILA system and the quality of interpretational comments, a number of reporting boundaries were agreed, namely that local testing would only report on 2 common mutations. The good news is that 85% of patients with an EGFR mutation are likely to have one of the 2 common mutations, indicating that they are highly likely to respond to tyrosine kinase therapy. This will be a real benefit for the majority of very sick patients needing an urgent treatment decision. So what are the benefits of tyrosine kinase treatment over traditional chemotherapy? Tyrosine kinase inhibitors are given orally. This in itself has many benefits. TKIs are less toxic, they improve the quality of life for the patient, they delay the need for chemotherapy, and they also can significantly extend patients' life expectancy. It's also worth noting that many non-small lung cell cancer patients are under the age of 50. Many have young families and dependents. Increasing longevity and improving quality of their life has a very positive impact, not just on the patient themselves, but on the whole family. How does this project deliver the Bevan principles? Well, what this development does is to ensure the needs of the patient are at the heart of lung cancer care. Right test, right time, right place. Keeping patients out of hospital for as long as possible is a very good example of prudent healthcare. In conclusion, testing for EGFR mutations in very sick patients with stage 4 non-small cell lung cancer can safely and economically be delivered locally within less than 24 hours of diagnosis using the iDILA platform. This can be done in a routine histology laboratory, enabling patients to have the opportunities to benefit from tyrosine kinase inhibitors therapy where appropriate. This improves and extends the quality of life for this group of patients. The next steps, once funding is agreed, we are ready to go. We will need to enrol in the required quality control schemes. We will need to communicate with clinicians on the new testing pathway, and it will be great to continue to build on the work of this project in developing a hub and spoke model for molecular testing. The Bevan project for me has been an excellent experience, providing new skills and opportunities to play a part in improving patient care. I would personally very much like to thank the Bevan Commission team, Prof Rich, Mr Adrian Thomas, Sean Charles and Mrs Lauren Fear for the time they have invested and the personal encouragement I have received from them on this journey. Thank you. Diolch yn fawr iawn.